Well, speaking of innovation, I know you really are now involved very heavily in the healthcare technology and services, but I know you didn't get there in a traditional path. Your background is you went to Auburn University, studied marketing and political science, and then you went on and did a law degree at Stetson and actually served as an attorney for a few years before you got into this industry. So tell us about how you made that jump into healthcare.
Yeah, I mean, one of the things that I started to realize as a lawyer in dealing with a lot of clients in different ways, whether it was physicians that we represented or families and clients that were dealing with healthcare issues and end-of-life issues and those kind of things, was just how broken the healthcare industry is and how much of healthcare for so long has kind of become industrialized and not necessarily focused on the patient and the caregiver. And so when we think about healthcare traditionally, I mean, you think about our grandparents and the way they went through healthcare. A lot of times it was a doctor coming to the house as a house call and the family being present and a support network and reinforcement for the patient who was ill. And the patient was dealing with a provider, but the physician was also dealing with the whole family. And over time, we've industrialized it. And so what we almost kind of inverted from the doctor coming into our home and our setting to us going into the doctor's setting on a 15-minute increments for the doctor. And so one of the things we realized and a few of us wanted to see kind of change was that healthcare really revert back to focusing on the patient and to focusing on the caregivers in conjunction with the providers to help everybody that was involved in the delivery of care. And so we started looking for ways to improve that and kind of disrupt the way that the status quo has been for a while now.
Well, that's great. So you saw that as an attorney. You were looking and helping people with their life plans, and then that's kind of what stimulated this idea.
Yeah, some of it was, I can a lot of different examples, but you can imagine a patient who's in the hospital near the end of their life that has had a healthcare power of attorney drafted up or a living will drafted up, but just the simple process of trying to get that to the physicians and a spouse who wanted to, or a caregiver who wanted to be coordinating with physicians but didn't have the authority or the power to do it because there wasn't a simple process of saying, okay, well, this is who the patient is. These are the meds or the disease states that the patient has. These are the documents that affect the patient's care. Just a very, very dysfunctional way that went about it. And so our original premise was that we thought patients should be able to own all of their information. We thought that the patient should be the owner of that it shouldn't be siloed in the enterprise or just out there in dark space. And so the patient should be able to own it. The patient should be able to share it with whoever they want. And the patient should be able to access it at any time and any place. And really our premise at the beginning of what became CareSync was that the patient is the only constant in healthcare. So if you take, Francisco as a patient and he sees, 3 different doctors and he visits a different emergency department, the only thing that's constant across that entire journey is Francisco. And so if Francisco is in control or ownership of his health information, then Francisco can get better health care. And so we almost laughed when we started looking at it that there are third world countries, there's something called a yellow book that some third world countries will use where the patient actually maintains this yellow book and they will hand that yellow book over to the doctor. The doctor will review the information that's in there and other providers' notes and what the patient has had and how they've been treated. And then they'll actually document in the yellow book what's happening there and then return the yellow book back to the patient. And we thought, well, gosh, technology is making our lives so much better in every other industry, almost with the exception of healthcare. And certainly since we began our journey in about 2010, really 2011 getting going, healthcare technology's come a long way. We still have a long way to go. But our original premise was that if the patient's the only constant in healthcare, how do we equip the patient to engage their caregivers and their providers to get a better healthcare experience? Unfortunately, and I think this is one of the biggest misconceptions about healthcare today is I think people think with the emergence of electronic health records that patients have kind of this master patient record somewhere or a longitudinal record of their journey through healthcare. And the reality is that there's a bunch of fragmented records. And so the hospital may have a portion of it, the primary care provider may have a portion of it, the cardiologist or the endocrinologist may have a portion of it. what we do is we go get all of that, and even down to the level of sorting paper and then populating the structured data into the CareSync profile, so that what a patient ends up with is a timeline that reconstructs every episode of care they've had or every appointment they've had, with the data and the provider notes transcribed into that, so they can filter their timeline and say, hey, what are all the visits I've had that dealt with congestive heart failure or with COPD or any other disease state, or what visits to this provider or this hospital. So that's one side of it, the direct-to-consumer side. The predominant focus of our business now, and candidly, this is where we got very, very fortunate, and I think in the healthcare space, almost underscores how broken healthcare is. But we basically said that healthcare needs to go this direction for real cost containment to happen, to ever move to an outcomes or value-based payment model and away from a fee-for-service payment model. Meaning, how do we pay a physician for keeping patients healthy rather than treating them when they're sick? That healthcare needed to go this route. So we've been down that path for about 4 years when CMS began doing a pilot in some of their own clinics, and they said, well, gosh, what if we provide these similar types of services to our patients? And they saw such savings that they actually created a reimbursement for physicians now. And so that started this past year. So the bulk of our growth and the bulk of our business is doing what is now called chronic care management, where we provide these services on behalf of a physician to those patients. So the physician would enroll their patients, the patients would get that benefit through Medicare, and then our job is to help make sure that we find gaps in care or help prevent unnecessary emergency department readmissions, those kinds of things. And so that's the other side of it. When I talk about, just a side note to tie the bow on that, one of the things that I think is a often missed fact in healthcare, when you are a healthcare innovator or a healthcare entrepreneur, the first question you have to wrestle with is, what distribution channels am I going to go through? Because everything in healthcare has to be through a distribution channel. So that may mean that it's an insurance plan that's providing it. That may mean that it's going through a hospital. That may mean that it's going through a physician, but it's never going straight to the patient. And that's one of the things I think we have to change about healthcare if we ever want to have this kind of consumerism effect happen in healthcare, is to empower patients with their own data and with the knowledge that it takes to become a consumer, and then to be able to consume the goods or services that they truly need in conjunction with those distribution channels.